Speaking and reading. Speaking and reading. So tonight we're going to have a conversation. Yeah? Tonight I'd like to thank the panelists, the Honourable Minister who's going to give the keynote, for their willingness to engage in conversation. So unlike a lot of the events you may have gone to this week, none of our panelists have a pre-prepared question. They are going to be on stage speaking in response to the Minister's keynote statement, and then we're going to have a conversation with that. And I'm going to ask you to join in that conversation as well. So I'll be walking around trying to get some of your thoughts. You know, we've got some of the Junior Doctors Network here, we've got some early career people, people from different civil society organizations. We're going to get you engaged in the conversation as well. And what is it that we're trying to achieve? We want three objectives for today, and it was in the program. We want to really look at the reports that the Director-General submitted to the World Health Assembly today on the issue of human resources for health, and how do we operationalize those? We want to look at how we go beyond Geneva. It's wonderful that we gather and convene in this process, but how do we take the discussions, the decisions into every single country to actually take this work forward? And how do we do that with the support of many different partners, different African initiatives, global initiatives, other bilateral and multilateral initiatives? And in particular, we want to also think about how do we learn from each other? Because we must make sure that underpinning our work is an evidence base. And an evidence base which is not just the scientific peer-reviewed publications, but an evidence base which is in that operational experience with the implementation research and everything else. So that we're underpinning to learn from you. So whatever is going on at a country level, we can learn from that to put it back into normative guidance. So that's the three objectives. It's a bit of a social experiment, an expériment social, non, ministre? Mais on va voir. We'll see how we get on. So please come with that intention. That's the reason why we invited you to have a drink first, so you'd be more willing to have a conversation with us. So let me start, but first of all, I'm going to invite two of our first speakers up onto the stage. Dr. Pooja Yeramili from one of our supporting partners, Seed Global Health, and the Honourable Minister, Minister Tedesi from Ethiopia. Please, you can come and join me.
Your Excellencies, Honorable Ministers, respected dignitaries, distinguished guests, it is my honor to welcome you to this critically important event tonight. From Resolution to Action, Investing in the Health and Care Workforce, co-hosted by Ethiopia, Alliance for Health Policy and Systems Research, Frontline Health Workers Coalition, IntraHealth, and Seed Global Health. First, I want to applaud all those who led and supported the Resolution on Human Resources for Health. And while it's an important step, I want to remind us that it's often easier to talk about the pandemic in terms of broad policy goals than it is to talk about the realities of healthcare workers on the ground. The rhetoric is that we are heroes, but what a burden it is to be called a hero when you never signed up to fight in a war, but it's your duty to. What a burden it is to foresee and carry the tears of our patients and their families as they confront their suffering. What a burden it is to feel that you could be doing more harm than good on the front lines without protective equipment, a potential vector of disease to your patients, to your friends, to your family. I wrote these words at the start of the pandemic, but they remain relevant today. At many points amid the constant flooding of our hospitals over the past 2 years, I stopped feeling like a healer but a harbinger of death, knowing that the only healing I could offer my patients, kindness and time in their moments of darkness, could prove impossible to give at the 27th hour of a long shift, when other patients equally needed my attention. And while this is a glimpse of my own personal experience, health and care workers around the world, challenged by long-standing critical staffing and resource limitations, shoulder even greater burdens. Almost 10 years ago, I traveled through Southern Africa, interviewing healthcare workers who had contracted XDR-TB, who continued working despite their symptoms due to staffing shortages, until they were far too ill to continue. These health and care workers have always and continue to cope with the physical and mental exhaustion of long workdays, the moral distress of rationing limited time and resources among their many patients, the constant threat of occupational exposures. At my hospital, it is often said that we must take care of ourselves before we take care of others. But when policies, funding, and systems make it impossible to do so, all of us here bear responsibility to fundamentally change them, to take care of our health and care workers so that they can take care of our communities equitably around the world. It is these daily realities upon which our policies must be grounded. As a healthcare worker myself, and as the policy advisor for SEED Global Health, I implore you for your commitment to real action. Thank you.
Thank you very much, Dr. Puja. That's just a reality check. You know, I think every conversation about health and care workers should have a health and care worker at the table giving us that lived experience on a daily basis. May I now have the honor to invite the Honourable Minister from Ethiopia, Dr. Leah Tadesi.
Thank you, Jim. I hope you can see me. Good afternoon or good evening, everyone. And I really would like to appreciate all of you coming here today, as it has been a long week and it really shows your commitment to this agenda. And I would like to start by recognizing the honorable ministers here. We have the Honorable Minister of Central African Republic, Minister Pierre Somse, Honorable Minister of Gambia, Amadou Lamine Samate, and Honorable Minister of Namibia, Dr. Kalumbi Shangula. And I appreciate your presence, Dr. Ahmed Ogwell, Acting Director for the Africa CDC, distinguished guests and participants. Let me start by first acknowledging today's decision in the 75th Assembly of the World Health Assembly on human resources for health. We have a new resolution to action, and I believe this requires an applaud. Thank you. We all need assistance, you know. Over 100 member states co-sponsored today's resolution that Ethiopia and Croatia introduced. And my thanks and appreciation to my team, the member states, and the Secretariat for their support. And I would also especially like to thank the whole team at the Health Workforce Department for WHO, Jim and all his team, for all their work to facilitate this. And I would like to also thank the Alliance for Health Policy and System Research, Frontline Health Workers Coalition, Intra-Health and SEED Global Health for co-hosting today's side event with Ethiopia. Ethiopia is proud to be a champion for human resources for health, both nationally, regionally, and globally. Ensuring that we realize the promise of the World Health Assembly discussions and consensus obliges us to commit to take our resolutions to action. Throughout this week, there were numerous sessions and side events that have underscored the importance of investing in our health and care workers. In the last 2 years, we have become acutely aware that a health system is only as strong as its people, the people, which are the health workforce within it. Each successive disease outbreak and situation of conflict and violence spotlights their role their dedication and sacrifice. Yet we have not fully advanced from attention and appreciation to investment and action. We must immediately act to sustain, strengthen, and optimize the workforce. With every shred of our commitment, our influence, our purses, and our actions, we should do that now. So, but the question is, and today's main discussion point is, what do we need to do now? We heard in today's deliberations from so many member states and partners that guaranteeing protection and safeguarding our health and care workers is a priority, alongside which we need to strengthen competency-based education, strong governance and regulation, decent work and retention strategies. This must be supported by domestic and other financial resources to realize policy and investment decisions. And we must engage political commitment, country leadership, multi-sectoral collaboration, and partnership. The multi-sectoral nature of this is key, as we need to engage education, finance, health, gender, and labor ministries on coordination and decision-making that brings additional value in our actions. In Ethiopia, we're focusing and working towards achieving these elements. Ethiopia's National Health Workforce Strategy addresses workforce ethics and professionalism, pre-service and in-service education, training and employment, delivering compassionate patient-centered healthcare, and enabling community and stakeholder engagement. We have invested in equitable and accessible health services and employment and career opportunities for women and youth. We all agree all occupational groups must be enabled with fair pay, continuous learning, decent work, support, and retention. And this should include from our community health workers to our different specialist doctors in all mix of health workforce. And we must integrate gender perspective into all aspects of health systems and national strategies. Colleagues, let me turn into the Working for Health Action Plan that we just adopted. Over the past 5 years, we have reduced the 18 million health workforce shortfall to about 15 million. But this progress is unequal between regions, and low-income countries are still bearing the largest percentage of this shortage. And it's unfortunate, as you may all know, in some of our countries that we have shortage, there are workforce that we are not able to employ because of lack of resources. The action plan lays out the needed multi-sectoral actions to accelerate investment in workforce education, skills, employment, safeguarding and protection to 2030 to address these inequalities. It emphasizes the importance of health and care workers to population health, health system sustainability, but also for economic prosperity and social protection. So we must also protect and safeguard our health workforce by providing psychosocial support and mental health services and protecting from occupational hazards and violence, harassment, and attacks. And we have seen more of this, particularly in the pandemic and also in the different challenges like conflicts we have faced. We must commit to enabling work environments, enhancing competence, acknowledging and safeguarding our workers to ensure high performance and productivity towards the realization of UHC. This can only be achieved, as we earlier said, with multi-sectoral collaboration and partnership at all levels. Our collective effort and work must be country-led, with regional and international initiatives aligned with and supporting our national workforce strategies, investment plans, and ambitions. There is no health for all without health workers and without the leadership and partnership of government, national institutions, and workforce organizations. And as we work to revitalize economies, create employment opportunities for women and young people, and improve health, population health, it is indeed time to leverage our domestic and development financing and investment to transform and expand education, skills, and employment opportunities. I think the different discussions we've had this week have given us a lot of insights on what is possible to be done. And we have also a lot of good experiences that we can share from each other. It is time for all stakeholders and initiatives, and Africa, including the Africa Union Health Workforce Task Team, the Biden Initiative, the European Union Initiative, COVID-19 efforts, all to lean in and leverage the fruits of enabling country-led partnership. And it's time to put our money where our mouth is and fully support, finance, and implement the Working for Health Action Plan and its global agenda. The previous plan, if you may not know, was funded at 10% only, but even that 10% funding for the previous plan has achieved a lot. Then we can think how much further we could go if we mobilize and increase our resources and partnerships collectively. And it perhaps is good to remind all of us of the African Ubuntu, I am because we are, and the late Desmond Tutu said, you are connected and what you do affects the whole world. When you do well, it spreads out. It is for the whole of humanity. So this is a call for all of us to do well, to invest on our health and care workers, because it is for health systems, for all health workers, and for all our people. And I wish us very good discussion and dialogue, and as Jim put it, a very free and open discussion to really take us, to move us forward for action. Thank you very much.
Thank you very much, Dr. Tadesse. Inspiring words. That's the discussion we're about to have. So I'd like to invite our two opening speakers, if they could return to their seats, and invite up our panelists who are going to take us part in this conversation. If I can invite Dr. Neil Squires, Polly Dunford, Sherry Nguyen, Duncan Jones, and Dr. Ahmed, if you can as well, please. Give them a round of applause, people. Yeah, no, come on. Where do we have the other microphone? Microphones, please, team.
We have one on.
Yeah, you're all, oh, they've all got mics.
I think so.
Okay, excellent. So, we just, as the minister said, we've just adopted a resolution, over 100 member states agreeing to take that forward. But the minister talked about country leadership with partners and with the work and support of different initiatives to help drive that action. And what we've got represented in our panelists tonight is Dr. Ahmed from the Africa CDC, who brings the benefit of being part of the African Union and the African CDC's new public health order and the commitment to drive that forward. We've had two events earlier this week hosted by Kenya and the African CDC AU, talking about the opportunity to really take forward this power against the Africa 2063 program for a healthy population that can work and healthy children can learn was one of the expressions I heard. Sherry Nguyen is coming to us from the US Permanent Mission here in Geneva, and we're going to be asking her some questions on the announcement just recently from the President Biden and Vice President Harris and their administration's announcement of a global health worker initiative. Professor Neil Squires joins us from the UK Health Security Agency, who has led part of the COVID-19 response and all the public health efforts in the UK, but also with European and international partners. And he's going to be talking about the roadmap that was published with the International Association of National Public Health Institutes and the global academic network of public health schools. And guess where they are? In every country around the world almost. So they are representatives of the member states, talking to us about their roadmap on public health. And Polly Dunford, who's the chief executive and president of IntraHealth, and representing also the partners from the Frontline Health Worker Coalition, is going to give us some different perspectives there. And again, I want to be having a conversation. I want to be exploring some of the comments. I'm lucky, I've got a printout of the speech. But just from your thoughts, let me start with Dr. Ahmed, please. Some thoughts and first reflections on what you heard in the Minister's remarks that really resonate with you individually and with the organizations that you represent?
No, thank you. Thank you very much, Ajimenda. Good evening. I think it's still afternoon in my head after all the debate around the health workforce today. Let me start by saying that at Africa CDC, we started the conversation on health workforce before the pandemic. And there was not too many sessions, events, speeches dedicated to health workforce at that time. And in 2017, we started the conversation around the need for health security to be approached differently from the traditional way of waiting for an outbreak, epidemic. There was no pandemic then. And then we rush in, we do what we need to do, and then we rush out. And many times when we are rushing out, we are often picking the best health workforce from where there was a problem by giving them good jobs in Geneva, New York, and elsewhere. So we deplete where the problem was. Many of us are part of this cycle. Now, when the pandemic came, African heads of states have met many times to discuss and guide on what needs to be done. And the core of every discussion has been around how do we prepare better for the next one? And the core of that preparation will always be health workforce. The right types, the right numbers, deployed in the right places at the right time. And that's how Africa CDC, the Africa Union, came up with a new public health order. I will not bore you with all pillars, but one of the key pillars is the need to strengthen our health workforce on the continent. Again, before the pandemic, the Africa Union Assembly already made a decision that we needed at least 2 million community health workers deployed across the African continent within 5 years. The 5 years are coming to an end in 2025. And so far we have deployed about 1 million. So we are just halfway there. This was a direct decision. This is action in as far as health workforce is concerned. Back in 2015, after the Ebola crisis, again, the heads of states decided that we needed an African volunteer health corps. Africa CDC is coordinating this. We have about 800 or so different specialities we need in health emergency response. And that, again, is a decision that is in action. So if there is an issue, an outbreak, we pick those who are available, we deploy as is appropriate. Most recently, last year, when the Africa Union Assembly decided to appoint His Excellency President Ramaphosa of South Africa as the Africa Union COVID-19 champion, he set up a commission, the Africa Union COVID Commission, and that commission has work streams. And one of the very first ones that was activated was the health workforce task team. Its remit is very much in line with what we are discussing now. How do you guide the gathering of evidence in as far as health workforce is concerned on the continent? Secondly, what advice will they give the Assembly in as far as strengthening health workforce on the continent is concerned? And third is research into the types of cadres that we need, their numbers, and how they can be able to be best deployed. So for us at Africa CDC and the Africa Union, we see our next steps in as far as taking policy to action is concerned to be divided into 4 parts. One is the need to support countries to commit to training the right health workforce. Not just train because that particular cadre exists in country Y, which is thousands of kilometers away, but it must be a cadre that is useful for that particular country. Secondly, is to facilitate a clear career path for those who are being trained, so that they feel comfortable and motivated that they are going to stick within an area that allows them to grow professionally. Third is remunerate them properly. Don't train them and then you don't pay them. It's the only way that you can be able to retain a good workforce. And finally is a good feedback mechanism on the types of health workforce that we are training, the numbers that we are training, so that we are always calibrating based on the most current situation on the ground. So this is the way that we at Africa CDC and the Africa Union are taking all the policy advances into actual action that makes a difference on the ground. This will be my response to Minister Leah's very eloquent and detailed presentation. Thank you.
So we've heard, it's important what we're hearing here. This is President Ramaphosa, President, with the African Union at the heads of state level. Part of the challenge that we've seen is that, with all due respect to the ministers of health, you do rely on many of your other partners in the cabinet to help you take action on the social determinants of health, on the education system. It's not, we can't point a finger and say it's the minister's fault. It is a multi-sectoral challenge that we've had to deliver. And so we've got another presidential initiative now from President Biden, who's put forward very, very similar priorities: education, making sure we've got the right people, the right jobs, the right occupations, pay and pay equity, making sure we remunerate, and data. Very similar priorities in that initiative. And he's doing the same thing in the US, just to be aware. It's not uniquely a global initiative. He's actually introduced protections and safeguards in the workforce for all American health and care workers, and especially for women health and care workers, as I understand, as well. So Sherry, Noam, please, just some thoughts from what you've heard from the minister, from what you've heard from Ahmed, how this multi-sectoral nature, about how presidential initiatives can work together. Please, your thoughts.
Thank you. And thank you so much for inviting me to be on the panel and join the discussion tonight. And thank you very much for your remarks. And I look forward to hearing the discussion on the panelists, and thank you, Her Excellency, for your keynote address. So the US has been involved with health workforce for many, many decades. And the COVID-19 epidemic really highlighted some of the challenges, as we all know, that we've been discussing this week, that we've been discussing in plenary, that we've been discussing in committee. And the health worker shortages really have impacted, not only what's been happening in our countries, but also our families and the pipeline, and of course, the provision of services. And so the Biden-Harris administration introduced something called the Global Health Worker Initiative. And this is a bit of a vision or an architecture. I know we've been talking a lot about the global health architecture these last few days, but here in Geneva at WHO, this is an idea, a vision for something that would create a framework for health workers globally. And so you might have heard in some other sessions where Assistant Secretary Pace has spoken, and some interventions on the floor by the US, that the Health Worker Initiative is really imperative. It's going to be an imperative initiative to build capacity and respond to not only the immediate needs, but to build resiliency for the future. And so the Health Worker Initiative has 4 main pillars. And I just want to say too that all of these themes are not anything that you haven't heard before. These are all things that we've been discussing, and just as you've been discussing the African CDC, the AU African CDC agenda, that this is all very much in line with the priorities of the Working for Health agenda and the Global Health and Care Worker Compact. So the first pillar is protecting health workers. The second is expanding the global health workforce and accelerating economic development. The third is advancing equity and inclusion. And the last is driving, investing, technological advancements and innovation. So what do we envision in each of these pillars? So here are some ideas, and then I'd like to get to the minister's point of, well, what are we going to do? So in the first pillar, protecting health workers. I mean, we've seen this not only recently in a number of different countries, but over many, many years of needing to ensure that health workers are better protected from violence, harassment, and discrimination. And we also want to make sure that health workers are prioritized for vaccinations and PPE. And also, as Her Excellency mentioned, making sure that the health workers have access to mental health services and support that they need. In terms of health worker gaps, we envision that we would look at creating pathways, just as my colleague had mentioned, and expanding paid employment opportunities to have a more diverse workforce, but not only working in the public sector, but also looking at the private health sector and how we can help countries to plan and manage a multidisciplinary health workforce configuration that really is equipped for local populations. But creating the health workforce is not just enough, right? And we know that we need to keep them incentivized. We need to ensure that they have fair pay. We also need to make sure that there is not harassment and violence in the workplace so we can help with retention. So we know that the global shortage of health workers is also due to some of these things. The third pillar was advancing a more diverse cohort of graduates. And these are efforts to include people from different racial backgrounds and ethnic backgrounds, geographic backgrounds, including gender distribution and geographic distribution. And then lastly, the initiative aims to harness some of the technological endeavors, such as telework or simple technological apps, phone, tablet usage, to be able to equip health workers to have the ability to be more efficient, more quality integrated at the service delivery point, and be able to extend the reach of our services beyond. So how are we going to do this? So right now, as a start, the US government is working with our team in Washington, DC to look at harmonizing technical guidance and aligning how we can see there might be points of strategic entry to look at targeted investment and impact. And also, we're looking at aligning the health worker initiative to the US gender policy. And so this is something that we would like to get some ideas on with you in your countries as you are aligning your health worker policies along with social sector and also gender. How are you doing it and how is it working? And then additionally, we hope that this health worker initiative will serve as a framework for better coordination with the partners, like in G7, African Union, philanthropic partners, so we can be more effective and more strategic with investments and support to look to see what the country and the region needs to bolster the workforce. So we would like to see, and we'd like to get your ideas, and we can have this discussion today, around how do we create like the central forum or platform for doing this. We would like to use some examples that already exist and build on them, but how do we create like a global architecture or a framework that we can do this? One thing that the US also would like to introduce and discuss is how could we create indicators so we would be able to report and be able to ensure cohesion. And so we're looking to utilize existing indicators for the Worker for Health and for the Healthcare Compact. And so just finally, I'll just say that we want to hear from you. We want to have a discussion and collaborate together to ensure that we have stronger accountability and that we can develop locally led solutions for this problem that we have with health workers. Thank you.
Thank you. Thank you very much, Sherry Nguyen. So there's a couple of points there about platform. Polly, I'm going to come back to you on that, the platforms. Gender. such a critical issue. We've heard lots about it. We have Dr. Magda Raballo in the room as well, one of our former minister, former WHO staff. I think everyone knows her. And now the Managing Director of Women in Global Health, championing the role of women in the workforce, working with us to really push that agenda. Magda, I'm going to come to you on that point in a moment. But Neil, we've heard about education. We've heard about competency-based education to responsive, with under government stewardship and government leadership. And that's what you're doing. It's not presidents of countries, but it's presidents of international associations, presidents of national associations. Please, just some thoughts and reflections.
I was very impressed by the content of the speech, but there were three particular elements that struck me, and I'm probably going to go slightly off-piste here in terms of focusing in on some keywords. So there was protect and safeguard the health worker, the reference to mental health and psychosocial support, and training and lifelong learning. And for me, it's about recognizing that at the heart of the health workforce as a broad concept, there's an individual person. And I think back to my own days when I went to be a VSO doctor when I was 27. I ran a district hospital in Malawi. Was I trained to do that? Did I have the skills and competencies? I'd gone straight from medical school. I'd had some GP training, but I was given a week's training in obstetrics in the district hospital. I was expected to do cesarean sections. So this is the reality for people in many countries. They're not adequately prepared for the challenges that confront them. And that isn't something that you just get on. We do get on with it, but it has consequences. There are mental stresses that come with that. And so you have to think, how do you prepare people for that reality? And how do you help them when they fail to cope with the harshness of the reality? And I think in the opening comment we heard from somebody who's dealt with the real tragedy of COVID, when you're having to deal with a problem for which there are no immediate solutions, and you see the stress and distress of patients who are disconnected from their relatives. So there's a whole set of competencies that we don't necessarily give to our health workforce in their training. So we have increasingly, in the UK, we've developed a competency-based approach to training. So it's not a question of, as I did myself, you learn the facts, you apply the facts. You actually need to be seen dealing with cases, observed, your ethical approach, the way you engage, all needs to be assessed. Your mental resilience in times of stress, your ability to cope with difficult circumstances. These are all the things that make effective practitioners. So we do need a training program that is based upon ensuring that the people who are going to be delivering critical services, including public health service, not just the life-saving clinical services, but dealing with populational health, have the skills and competencies to do the job that they need to do. And so one of the things that has been done in terms of developing the global roadmap for the public health and emergency workforce is to make sure that we are giving people skills and competency-based training that equips them to work in the roles that they will have to perform. And that includes ensuring people have leadership skills, ensuring they have emotional resilience, ensuring that there are systems in place to protect them when they're not coping with the stresses that they face, ensuring that they have mentoring skills, that they can recognize the gaps in other people's performance and step in and help them and support their colleagues when that's necessary. So to do that, you need the schools of public health that are working with young people, training them for a life that is going to be completely different from everything that's gone before, to work closely with them, but to understand the needs of the employers of those people, the institutions that will employ them. So this is why the International Association of National Public Health Institutions has been working with the schools of public health to promote competency-based training. And that is why, WHO's championing of this in the development of a roadmap is so critically important. Because unless we recognize that we start our medical health careers with 16, 17, 18-year-olds with very little experience, and we turn them into responsible professionals delivering critical services, then we're going to fail in the task. It's not just a numbers game, it's also about producing quality, capable individuals.
Thank you very much, Neil. This is the roadmap that Neil has been talking about is on the WHO website, the IANFI website, the ASPA website, the Global Academic Network. Take a look at it, take an opportunity, be aware of it, because three very similar approaches to things. Polly, just forgive me for a moment, because I want to turn to some of our honourable ministers that are here and have heard some of this discussion going on. Dr. Somsay, we don't have translation, but unfortunately, but would you like, you've heard some comments here, you've heard some suggestions. Would you like to make an intervention, and what your thoughts? What resonates from the minister's speech? What resonates from the panel?
No, it's very down to earth first. So I already mentioned it yesterday, told you this morning. It's very down to earth. It's a very refreshing set of perspective. Let me give you just a practical example of how I'm experiencing issues related to this, calling for this kind of approach. In the Central African Republic, we are really in a crisis of human resource. So if you take the area of obstetrics, we have barely 200 midwives. Nearly all of them are in the capital city because of a combination, a conjunction of many situations, including security, women, but also, I would say, another type of security, family security. We have family, we have children, we cannot go away, etc. So then what to do? We need to reduce maternal mortality. We need to provide the population with high quality staff, secure delivery. In thinking, I found out that there was a problem with the university, the Faculty of Science and Health Science, that has been training also. They have almost stopped training midwife. So they are not producing midwife. In the fourth year, you have only 4 midwives in the third year that are getting ready to go. At this pace, how do we solve the problem? And I was curious to find out what is happening exactly. You have many young ladies, young people coming out of college with their baccalaureate. They are applying and they are not recruited. So I heard that the test, they are failing the test. They don't succeed to go to the university. So why? What I found is that because the training is given in French, because of all of this crisis, the level, the proficiency in French has decreased. But they have maintained the standard in French. So all the children fail. So I said, is French the measure of intelligence for people who are going to talk with the community in their local language? So I ask. So what I was saying, to cut short, what I was saying to the dean and to the Minister of Higher Education is that we need to start training in local language. We have a national language. It is this national language that is the working language in the community. And you do the test, they have, and this is what you said yesterday, or someone told yesterday, we need to be able to, we need to understand biology in their local language. So to come back to the competency-based training, but also need-based training. how the worker is going to be useful. So it's really important. There are other things but I wanted to give just this example to say everything that you have said is relevant.
Indeed, and it's an excellent example, Minister. This is the Right Honourable Minister from the Central African Republic. But the key point he's making there is how do we make sure that we're linking our education systems to our labour market needs and ensuring that we use competency education against popular. And the same logic is in the African Union Initiative, it's in the American Initiative, it's in the Public Health Initiative. Exactly the same. So we've got real alignment to the problems and challenges we've got there. Let me invite now the Honourable Minister from the Republic of Gambia, Dr. Samate, to please, your observations, Minister today, see and what you've heard.
Thank you very much, Jim. You didn't prepare me for this. Thank you very much. But I think the issues are similar when it comes to human resources for health in our region. The shortages are everywhere, but I'm happy my colleague mentioned the maldistribution. Most of them are in the urban areas and for various reasons. So there are various strategies the Gambia employed to get them to the districts. First of all, encouraging them, because most of them are young people who train in the urban areas. And all of a sudden, you give them a letter to go somewhere many kilometers away. But encouraging them and explaining the situation sometimes helps. But also putting things there that could attract them. You know, the rural areas now with electricity, good roads and water, you know, that motivates them. A young man who's used to the city, you take him to the village without electricity, you are really discouraging him. But also we had something by way of motivating them, which is results-based funding. The government did that with, in conjunction with the World Bank. Various parameters are measured, and then they are paid based on those measurements. And you know, they had additional incentives that the people in the urban areas didn't have. So that also encouraged them. But I think the bottom line is we need to train more people. We need to train more people, and collaboration is very important in that. You know, there are various institutions in our region that have training institutions, various countries that have training institutions. Let us get together. We see where the advantages are. And we have a forum that can allow for people to be sent to one country to train as midwives, another country to train as anesthetists, and so on and so forth. I think that collaboration is very important because we tend to work in silos, stay with our little advantages, and also stay with our little disadvantages. But probably if we complement each other's efforts, we can break those barriers. But I think one very important thing is the brain drain. We talk about, you know, shortage here and there, and we have a whole lot of our people working elsewhere. So this is a big challenge. But how do we keep them in our countries? Of course, we cannot pay them as they are paid elsewhere. But in Gambia, those we trained, we have a bonding mechanism for them. They have to work for specific periods, you know, for the government, but after that, they still go. Now, there are various ways. One of the ways is that we tend to invest in the primary level care providers who may not be very attractive outside, like when it comes to nurses. We have the community health nurses and the state-enrolled nurses. They are, so to say, trained for the localities. Those ones, they don't get the visas to travel and get stuck. But the state-registered nurses are very promising, and we end up losing all of them. But the good thing is those who have left, you know, when they criticize our health sector at home, so they stop criticizing. You know why? I just tell them, pack your bags and come and join us in the struggle. And I think that way they now stop criticizing, they all want to support. But I think just wrapping up, we need to train more people, we need to encourage them to stay, and we need to strengthen the systems. But believe me, whatever we do, if we do not train the competent people, whatever equipment or facilities we build will not make much progress. So the human resources investment is very important. Thank you.
Thank you very much, Minister. Again, a linkage to what African Union is saying about career pathways, a linkage to what we're saying about evidence and information. You know, how does performance and incentives result in better care and quality? There's a mixed evidence on that. We need more of it. Finally, I'd like to invite His Excellency, the Honourable Minister of Health from Namibia, Dr. Shangula, for your reflections. Welcome, Your Excellency.
Thank you very much, moderator, panelists, honorable minister, honorable ministers. Thank you very much for your excellent keynote statement and also the input from the panelists. It is true. We need health workers to provide the service to our clients, to our customers. What is the essence? The essence of them is to be able to provide quality service. Now, this is determined by many factors. It is correct that we put emphasis on the health workers, but I also want to draw attention of the House to one aspect of the cadres who are working along the health care workers, who can make or break. The success of the health workers depends on the support they receive from what we call support services. Now, imagine you have a nurse, you have a doctor, but he will need tools to work with. That person is not responsible for procuring this. This is done by the procurement officer. So it's a very important component of the health workforce. Then you have somebody who is responsible for the budget. It is a critically important that there is a budget provision made so that the tools which the health workers need to use in order to carry out their service is available. Why some of the health systems are not functionally optimally is because of lack of the support services. It may not be a question of money, but somebody must come up with a realistic budget that for this financial year, these are the things which will be required for the health workers to be able to carry out their work. If we mess up, it will mean that the service, the quality service which we aspire will not be achievable. It leads now to the situation where the health workers who have been properly trained, they have the competency, but they don't have the tools to work with. You will not have quality service. What happened to the health workers? They become demoralized. They will look for some other greener pasture because the work environment has not been made optimal for them to be able to carry out their work. When we do upgrading, we send health workers, nurses, doctors, pharmacists for upgrading courses. These people, they stay there where they are doing routine work. They are no longer doing it for the love of the profession, but they are doing it because it's routine. And of course, when there is no incentive, where there is no something to drive you to something else, the person will then remain at the same stage. So that the point I want to drive home is that as much as we really value and strive for sufficiency in healthcare workers, let us not forget the backbone of the health services. Those are the people who can make or break. I thank you.
Thank you very much indeed. Again, motivation. This is what the Global Compact is all about, protecting and safeguarding an enabling environment for people to perform. Polly, You've heard from 4 ministers now. So you've got some different perspectives. How do we do a platform? What's the role of civil society? What did you hear on the reflections from Minister Tadesse and our distinguished colleagues?
Well, honorable ministers, Honorable Minister of Ethiopia, first of all, thank you for your leadership. I'm inspired. I think the first thing that we need is alignment. We need high ambition. We need very lofty goals, very clear goals that we can all come together and stand behind. And I think that that's something that we haven't really had before. I think during the COVID pandemic, there's been so much talk about health workers, and we need to support health workers. And a lot of us have been engaged in many different conversations. But I think to date, we can all agree that it's been very fragmented, and in reality, hasn't resulted in as much support globally as we would like. Honorable Minister, I was struck by your citing the fact that in the last plan, only 10% of it was funded. So clearly, while there's talk about the importance of health workers, there isn't alignment, there isn't political will, there isn't that commitment. And of course, we do need the financial commitment, both domestic and international, to move it forward. So now, when we're talking about partnerships and framework, Sherry Nawan mentioned framework earlier, I think this week is giving me so much hope. I'm thinking of the momentum. Honorable Minister, you mentioned that 100 countries came together today to co-sponsor what we saw earlier today. That is incredible. This is real momentum at the highest level that we haven't seen before. The Africa CDC, the Africa Union, with the heads of state aligned behind the importance of the health workforce. This is critical, and I haven't seen it in my career, and we need to build upon this momentum. So what can we do? I think, first of all, we have very lofty goals. No ambition is too much, because we know we can all do it if we come together. We need very clear, crisp goals that we can all come behind. We need the data to back it up. And then we need to ensure that we have the metrics so that together we can hold ourselves accountable and see where we're making progress. And then we do need the financing. We need domestic financing, and we need international financing. And that's why it's so exciting that the US government is coming to the table with its initiative. And I hope that the framework that you're looking for, Sherry Nawan, is really the framework that was started today here at the World Health Assembly. I think that is the framework that we need. So what we need is to reduce siloing and fragmentation and bring everyone together. And together, I know we can do it. So in terms of civil society, I'm representing the Frontline Health Worker Coalition, a coalition of organizations that are passionate about the health workforce. In terms of generating a movement, we need advocates. We need constituents that care about women, youth, labor, human rights, all to come together for this effort. And I think that we can all work together to generate this enthusiasm, generate this advocacy. And I think the other thing that's really important is that the health worker voices need to be louder and at the forefront. So one thing that we're doing is we are working with health workers, so that their voices are at the front lines of calling for this change. We need them to be talking to politicians. We need them to be talking to stakeholders, and to all of us to hold us accountable and to ensure that we're bringing the political will, the commitment, the data, the plans, and the financing.
Thank you very much, Polly. Again, civil society wants to be part of this activism, advocacy for it, but we've got to underpin that with evidence, which means data. We've got to come back to the data to give to the advocates to make that challenge as well to come forward. We had a question and a challenge earlier about gender, women in the workforce. Magda, if I may, please, Dr. Raballo, you're an expert on this. In short, some thoughts on how we drive that question.
Thank you, Dr. Jim Campbell, for the challenge. Good evening, honorable ministers and distinguished guests. I think all that has been said are part of the challenges that we have been facing, but there is one big challenge that we tend to overlook. And until such time that we really make sure the data is used to incorporate that element into our planning, into our implementation, monitoring and evaluation, we will not get it right. The world has changed. We now have a huge workforce that is young, determined, dynamic, and they are not waiting for us to adopt the policies and do the long discourses. They are moving forward, and we need to adjust to that. Otherwise, we will never have health systems that can respond to the needs of our population. We have 4 ministers here. 3 are male, right? And we have 1 woman. And this is what our health systems have. Yet, 70 to 90% of the health workforce are women, but they are led by men. I'm not saying the men are wrong. We need the men as much as we need the women. The issues within the health, the issues around the health workforce, motivation, training, decent salaries, safety at work, social contracts that take into consideration the needs of women can only be taken care of adequately if we pay attention to the fact that most of the health workforce are women. And women has got needs that need to be taken on board. Women need to be on the decision-making tables. I heard my friend saying we need to bring the tables to the global south. I think we need to build our own tables, actually, because the tables may not fit into our doors. Let's build our own tables, huh? And I think Dr. Huma is listening to me. Yes. So really, we are saying women need to be on positions of leadership. Women need to be around the table. When we are framing those policies, let's listen to women. And more, we are having young women. Young women have different views for the world. They no longer see the world the same way as we see them. And we need to bring that into consideration. COVID taught us that the digital, the technology, and the issues around globalization are important. So I'm told we don't have much time, and I know these issues take long to be discussed. For too long, we thought that fixing health systems was about procurement, logistics, medicines, and things that are easy to buy, the entrance. The health workforce was the last to be thought about because it was a bit difficult. If we leave women behind, we will not have health systems problems sorted out. Thank you.
Thank you very much, Margaret. So we've got to make sure that we're always talking about women and health, not women's health, and the role of women as change agents, as providers, as carers, as leaders in our discussion. Now, we're a couple of minutes running late, but I think we've done well because there are actually 4 ministers and a former minister who have been taking the floor, and you all know that ministers will always take an extra minute here or there. But before I finish, I want to go to Dr. Kathinji Katahi, the Chief Executive of AMREF. We've heard about the new public health order. AMREF are a leader for that program, but also their work on education and training and making sure. Kathinji, from what Minister Tedesi said, what colleagues have said, please, just in a couple of minutes.
Well, no intentional speaking, that's why I was hiding behind there, Jim, but you found me. You found me. Good evening, everyone. Excellencies, truly appreciate the conversations here and the panelists as well. I want to be operational and petty. That's what I'll try and do. Because when we are here, we talk very high level, which is extremely important. And we talk about the health workforce, and we all agree. We preach to the choir. I think getting 100 countries behind, working for health agenda is extremely important. Now, let me try and, because that has been covered, let me try and now go to the bottom first and ask myself, I have been part of the team of the working group that was developing the Africa Health Workforce Task Team under President Ramaphosa. And we know that we intend to do the work that's being discussed here. But the constant question that's in my mind, Jim, is how. The how question is going to be extremely difficult because the conversation around health workforce is not new. IntraHealth, AMREF and others have been working on this question for very long, advocating for protection, more health workers, better payment. We have unions of health workers. They're on the streets almost every day. You know, I had and I must correct, I had a meeting with ministers the other day, about 5 of them, and 70% were women over that dinner. So, you know, Leah was one of them. Is it? No? Maybe 60%. Maybe 60, you know, Leah is trying to correct me. But let me go down to the bottom. First is that when we talk about the continent, we have a fiscal space challenge. And all these ministers sitting here will tell you, if they could achieve 15% of Abuja declaration, they'll probably employ more health workers and get more health workers. But we have challenges. We talked about Abuja for many years. We're still stuck at about 7%. So as we drive the advocacy message to invest more in health workers, we must also ask ourselves, what is possible now in what we have? We know that there are production challenges, the production challenges of getting more health workers and repurposing them to be fit for purpose. But we also know that we have an absorption challenge, that we have countries here that have many doctors and many nurses unemployed within the shortage. And that is the challenge, the dual challenge. They have a production problem, but we also have health workers who are sitting, but they're unemployed because the government can't afford them. Is the government refusing to pay them? No, they are not. Even if you worked out, Jim, and you worked out the available fiscal space for health, even at 15% Abuja, and even at increasing our tax efficiency in Africa, you'll be lucky to get more than $50 per person per year, per capita expenditure, public resources. So we have a huge challenge in the continent. So we must ask ourselves, as we resolve the fiscal space challenge, so that we have more money, so that we can employ more and pay them better, then we must ask ourselves, what other challenges can we work on? And this is what we want to look across the continent. And therefore, I'll highlight only one and sit down. One is that many of us, I have been a frontline health worker, there are many more here. I don't know how many of us here have worked in the front line. Nurse, doctor, you know, lab, pharmacy. Here we are. Now, when I went to work in the district, some of the biggest challenges were not my pay, though it was very little. I started off with $100 a month. $100 a month was my pay when I became a doctor. The challenges were that, and even for women, the challenges are that there are challenges every day as you do your work. And those challenges cannot be resolved because the facilities don't have resources. So I just want to say that as we resolve the health worker issue, we must revisit the environment, we must revisit the Public Financial Management Act, we must revisit facility autonomy, financial autonomy, so that when a woman goes and she's pregnant or she has a child and going to work, there is a way that the facility can determine how do we take care of the child as the woman works. Right now, you have to go to the center to get money to even get reagents for health workers. That's why they leave. They leave because they don't have a good working environment. So let's not dissociate the facility autonomy, the working environment from the health workforce issue. Thank you.
Thank you, Dr. Kathinji. So, we're going to ask a big round of applause for our panelists, for the ministers, if you'd like to just come down. And I'd like to invite Dr. Taisi again, and Dr. Ghaffar, the Executive Director of the Alliance for Health Policy and Systems Research, again to the podium, just to do this final closing section. We've heard of opportunities to tackle some of the challenges we're seeing around the world. We have clearly a global political momentum, heads of state involved in this issue, which is going to help us to take forward. Honourable Minister, you started tonight's conversation. You put forward some of your key remarks. We've heard from some distinguished panelists from institutions about their work, from the Honourable Minister. I wondered if you could give us some thoughts and remarks for us to be reflecting on as we take our flights, our planes, our trains away from Geneva.
Thank you very much, Jim, and really an excellent discussion and insights from all the panelists and honorable ministers and Dr. Magda, Dr. Gitinji. Really appreciate it, and excellent facilitation also, Jim, with all the insights. I think we have a lot of actions to take away that were outlined critically, and indeed what we need is really concrete action plans and action items to move forward. I think the main issues within the health workforce can be in 3 areas, I believe. But before I go there, I want to emphasize what Honorable Minister of Namibia said on when we say health and care workers, we are talking about all healthcare workers who are professionals and those who are working within the system supporting the healthcare. So it includes all, and otherwise we're not going to achieve what we want. So that has to be emphasized. But it starts from training. I think the first one would be the training piece. The education, of course, we need to train enough quantity, but also the critical issue of continuously calibrating what Dr. Ahmed said on what we need, the type of cadres we train, because sometimes we don't quickly revisit who we are training, how many we are training, then those challenges of shortage in one and excess in others is what we suffer also from. So we should have a system to continuously calibrate that, but also the equipping the needed competencies, not just the skills, but also, I mean, the health or clinical skills, but even beyond, like leadership, entrepreneurship, I think are critical ones that was mentioned. So I think the training and the investment in that regard is key. And in that area, I think Dr. Gitinji remembers, I mentioned it on the Monday discussion, the role of the Ministries of Health in the training, I think needs to be elevated, because in most areas we have to work very closely with the Ministries of Education to ensure that the needed competencies we need for the delivery of quality healthcare are incorporated, and I think that's one critical issue we need to elevate. The second is, how do we move them, those who are trained, into the workforce? The issue of that was recently mentioned at last by Gitinji. That's what the big challenge now we have. Not only recruiting them, but also deploying them to all the needed places, in the remote areas, in the centers where they are needed. So we should have a system and the finances for that. And I think this is also one area to elevate on how both domestic and other resources should be funding this gap. Because in most places, we all know that it is only relies on domestic funds on the recruitment piece. Recently, because we have now a large number of doctors who are unemployed, we had an initiative for a government matching fund soliciting donor funds to deploy more physicians to the primary healthcare centers, so that we address both the challenge of unemployment but also the quality of care. But we were only able to find one donor to start the project because there's not much interest in this area. So I think this is one critical issue to address. And of course, once we employ them, then how do we retain them in a motivated way where they can have high performance, high output to what we want to deliver? And I think remuneration is a key point here, but it's not just the money. Of course, that's very important. That's something we need to now push forward for governments to think of health workers. Sometimes it's difficult for governments to treat health and care workers differently from others, but that has to be challenged. And remuneration is key, but it's not just limited to that. It is about the environment that was mentioned. If they are not able to give the services they need with the needed commodities, the frustrations coming and they leave. And also beyond that, even simple things that makes their environment easier for them to work. In addition to that, just the workplace safety, sometimes as simple things like places where they can rest when they are working 24 hours. So we have seen that we have those rooms for male and women healthcare workers in the same room to rest in the same room, but we don't even think that's a problem. So simple things like this, availing daycare centers and others. So the environment and acknowledgement, mental and psychosocial support, a lot of pieces that there are to retention and motivation outside of remuneration that we have to think of. And I think all these need strong partnership with donors, partners, and government and other sectors outside of health, and also the needed finance. I think these are main areas. So going forward, I think we need to all work on having clear action items to how we move forward at country level, but also collectively, because if the agenda is elevated regionally and globally, then we get more momentum in countries. So let's continue to make this change.
So you talk about actions. What actions will you urge us to take? What actions will you consider we should be doing? And from yourself?
Well, it's first is, of course, because even if we discuss all these issues, each country may have specific challenges and specific needs. So we need to go back and really identify what are the key problems, but not dwell too much on trying to find out what are the key challenges or solutions, because we know those things. So it's about designing this, but gathering with first creating that momentum within country, gathering the different sectors, but we should be able to use the platforms that are set for us. For example, the African member states should be using the Africa Task Team to move this agenda forward, but it has to start at the country level with bringing the different sectors. So I would think for myself, I would go and start discussion with the different sectors of finance, labor, and of course, we already have some work that is started. So building on those and building on our strategies for concrete actions, but collectively as well.
Thank you very much, Minister. And a real champion. Credit to Ethiopia in this global discussion, and with all due respect to Gathinji in terms of making sure we'd go to the national level. That's what I started with when we came. How do we take it out of Geneva? But in Geneva, Ethiopia has sponsored 3 resolutions on health workforce in the last 4 years, and really helping us drive the discourse amongst the Africa group, amongst the Europeans and the Americans and everyone else. So thank you very much. Finally, then, let me invite Dr. Ghaffar. One of the objectives today was also about the underpinning research agenda. Dr. Ghaffar leads the Alliance for Health Policy and Research, how to give policy guidance, evidence, information to ministers to make those decisions. Dr. Ghaffar, your thoughts of what you've heard.
Thank you, Jim. So, honorable ministers, Madam Minister, leadership of partners, excellencies, ladies and gentlemen. I think I would like to share 4 points before I come to the research. I think one thing we all need to recognize that most valuable and precious asset of a family, community, organization, or health is people. So we have to recognize that people are very, very important, and I think that's the whole thing we are discussing. But I think we heard about issues about gender, we issued about harassment, issues about management, and I manage a team and I have managed hospitals and the districts. I think the easiest is to manage the money, then infrastructure, and the most challenging is to manage the people, because they are people, they're human beings. So I think that we have to consider that people are not products. They are people, they're human beings. And when I say this thing, I think generally as a manager, we try to be more efficient and effective because we have some pressure either from the senior management, funders, or the donors. And we look to those things and forget the people we are working. We have the responsibility to respect them and motivate them. Now there are 3 points I would like to make. One, I think we are very proud of all of you as member states who has helped, especially the Ethiopian government and the people of Ethiopia and the leaders from Ethiopia, but also other partners, and resolutions are very important triggers for change. However, they are only one piece of the puzzles, and if we really want to see that resolutions are realized, I think I would like to bring the argument which came in the last from our friend Gitanjali is the fiscal space. We can have a lot of resolution, we need this number, we need this number of dollars, we need this workforce with this quality. Nothing will happen if we are not allocating more allocation of our GDP to the health workforce or to the overall health. And that's a challenge, and that's where the leadership comes. And there, I think people talk about platforms. We talked of like networks. We talked about partnership. Those are all important. However, it is always easy to talk about platform and the partnership. It's very difficult to bring together the people who have an interest, which is a public interest. We all have our own interest. I, as a director of the health policy and system research, I sometimes compete with Jim because that's the same money we are getting from different like donors or even from the Director General's office. So I think in the end, we need to do whatever we are supposed to do for the people and policymakers. And that is where I would like to have another thing, that if we really want to recognize the context of these resolutions, things are very different in Namibia than in Ethiopia. Even in Ethiopia, there are different districts and provinces in the states where the situation, issues of access, quality, affordability, gender, culture, religion. So I think in the end, we need to all be very appreciative of the situation at the ground than what we decide either in Boston, Baltimore, London, or Geneva. These are important things which we need to come together, but I think that in the end, we need to go back and talk to the local leaders and the people. And the last thing before we close is the leadership and capacity to generate local knowledge. I have worked for the last 20 years in the global health research at least, and there have been WHO resolution, there have been other member state resolutions about allocation of the funds for the research, either by the funders or the national government. I can tell you at oath, there's not one country from 2000, there have been 2004 Mexico Summit, 2008 like Bamako Forum, and then nothing has moved. Not one country has invested the needed resources in research. So I just want to give you an alert. Important to have resolution, important to have the action plans. They look fancy, beautiful. Donors are happy, we are happy, the national governments are happy. In the end, we need to implement that. And for that, we need to have a local knowledge. Sadly, there's a lot of research commission conducted and supported, but those are our friends from Hopkins, Harvard, or London School of Hygiene and Tropical Medicine. They publish in Lancet, and they're very happy to give us an authorship. That's not what we are looking, that's not what needed. What is needed, how can we respond to the demands and the needs of the policymakers and the program manager? Can we solve their headaches? We can publish that. I publish, Jim publish, I'm sure you're all published, but that's not our primary purpose. Our primary purpose is, can we solve the headaches or the policy problems of the policymakers and the program managers? And as I said, context is different, power dynamics are different, needs are different. We should all try to respond to the needs of the national policymakers and then help them local knowledge and policy level knowledge which can help them. And for that, again, we need funds for research. And I have to finish because we are getting out of time. In my own country, some of you know, I don't have to name it. The Medical Research Council there, 90%, 97% of the budget is the salaries of the staff. And 3% is for research. So you can imagine wherever they get the money, they will go and do that research. So I think in the end, I want to appreciate again the support, the partnership, the alignment, and the work you have all done, either as the funder, donors, national policymakers, activists, or even as a WHO staff. We are very appreciative, and we are looking forward to work with you. And in the end, Jim, thank you very much for doing this wonderful job and showing the leadership in a very difficult time to you and to your teams. And we're looking forward to further strengthen our collaboration with all of your partners. Thank you very much.
Sorry, Jim, before you close, I just realized the Undersecretary of South Sudan, who was Victoria, is here. Thank you for being here, and sorry we didn't give her the chance. I just saw you. I hope I didn't miss any minister. Thank you, please.
Which would have helped us with our gender balance and then dealt with the challenge as well. So that's okay. Your Excellencies, ladies and gentlemen, colleagues, thank you very much for your time. Thank you very much for joining this opportunity for a bit more interactive. We've learnt an awful lot to go. We don't stop here. This is the resolution to action we want to take forward. We've been having some excellent conversations with our partners in the African Union about what we can do next, what actions we can do. Convening multi-sectoral African leadership, putting evidence, research and information, solving what we believe are some of the opportunities to take forward. Similarly with the US colleagues, similarly with the Global Public Health Roadmap, we've just started conversation with the European Union. On Friday, they announced a new global health strategy. We're trying to encourage them to come together on the workforce needs, make sure we come forward. We will also have, in April next year, the 5th Global Forum on Human Resources for Health. My challenge to you and what our action will be, we want to ensure that this partnership, this working together, leads to major statements not only in the actions that we can take at a regional level and expanding this to all regions around the world, but really informing all the preparations that are ongoing for the halfway point of the Sustainable Development Goals. In June next year, we are halfway there. What's the big push that we will be taking? How do we get the fiscal space, the funding, to put the words of the resolution into action? So a big round of applause to all our panelists and speakers. I would like to invite the panelists and speakers, all of them, if they can congregate on the stage, just so we can get the family photo. And then I invite all our guests. Refreshments are being served. Continue the dialogue, continue the conversation. Engage with our distinguished panelists and guests. Tell us your ideas to take forward. But just before the panelists, guests, we can join them there, or yes, with all the ministers.